Hello, everyone. I'm Jerry Vockley from the Children's Hospital in Pittsburgh, and I direct an organization called INFORM, or the International Network for Fatty Acid Oxidation Research and Management. And I'm going to answer some basic questions about fatty acid oxidation disorders to try to help get you ready for the upcoming MitoAction Fatty Acid Oxidation Family Symposium. So if we can have that first question up on the screen. And it's very basic. What is an FAOD, or a fatty acid oxidation disorder? Let's start by talking about what fatty acid oxidation is. Fatty acid oxidation is a biochemical pathway, a metabolic pathway that functions in all cells, and it helps generate energy. It generates energy under circumstances where the body is either fasting or under stress. So exercise, even psychological stress, and your body just needs more energy. And the way it works is that we all have fat stored in our bodies. It comes from the food that we eat. Anything you take in excess over what you need at the moment to keep your body functioning gets stored as one of the things that gets stored as fat. And so when you're not eating, your body can call on those fat stores, bring them into your cell, and then start breaking the fats down piece by piece to generate energy. Fatty acid oxidation is usually divided into several components. The first is the process that's required to get the fats into the cell and then into the mitochondria, the little piece of the cell where the enzymes actually work, and that is a process that requires the molecule carnitine, which itself has to be transported into cells, and then a set of 3 steps that bring the fat attached to the carnitine inside the mitochondria. The 3 carrier proteins that do that are called carnitine palmitoyltransferase 1, or CPT1, carnitine acylcarnitine translocase, or CACT, and then carnitine palmitoyltransferase 2, or CPT2. Once that fat's inside the mitochondria, the action of fatty acid oxidation starts occurring. And what enzymes are used depends on the size of the fat. The fats that occur naturally in the body are all what we call long-chain fats. Fats are strings of carbon molecules hooked together. And most of the fats that are in your body are stored as 16 or 18 carbon chains long. And that requires what's called long-chain fatty acid oxidation to occur. Each step of fatty acid oxidation knocks off 2 carbons at a time, and then the process starts over. So there are 4 steps that occur, and you knock off 2 carbons, and you get a 2 carbon shorter fat to go through the next cycle of fatty acid oxidation. Once you get down to about 10 carbons, you switch over from the enzymes of long-chain fatty acid oxidation to medium-chain fatty acid oxidation, and then it's an enzyme called that does the last bit of fatty acid oxidation for short-chain fats. Now, if that's what happens normally, if that process breaks, it's called a fatty acid oxidation disorder. Each of the steps that I talked about is carried out by a very, very specific protein called an enzyme. An enzyme is a specialized chemistry factory that does one chemical reaction very, very efficiently. And so if you string all of these enzymatic reactions together in the right arrangement, you can break down a fat completely from this 16 to 18 carbon units all the way down to the very last step where you get two carbon fat units, or 2 carbon chemicals out of that short fat unit. Each of those proteins or enzymes is the information to make them is stored in our DNA, the genetic information in our cells. And if there's a mistake in that genetic information, you end up with a a protein, an enzyme that doesn't work, and that creates a block in fatty acid oxidation, and that's a fatty acid oxidation disorder. The exact flavor of fatty acid oxidation disorder is based on which of those enzymes is not working properly. And typically we talk about the disorders of carnitine transport, the disorders of the carnitine transport of fatty acids into the cells, sometimes called the carnitine cycle, and then long chain fatty acid oxidation and short chain fat or medium chain fatty acid oxidation. So that's an FAOD. The next question is, are fatty acid oxidation disorders passed from parent to child, and are all children within a family typically affected by a fatty acid oxidation disorder? Let's go back to Genetics 101. We all have 46 chromosomes in our cells. Those chromosomes are packages of genetic information. They're arranged in pairs of 23, and you get one copy of each chromosome from your mother and one copy from your father, and you only pass on one copy to a child. Those chromosomes make up the story of our body, if you will. And each chromosome has a chapter. Now, a chapter is made up of a lot of different words, and those words are the genes that are arranged along the length of the chromosome. So what that means is you have 2 copies of every gene and you get one of those copies from your mother, one from your father, and you pass on only one to a child. Now, it turns out that most of the time, as long as only one of those copies makes a protein that's working, you're just fine. In other words, there's redundant information there. And it's only if by chance you have both copies not working that you have a fatty acid oxidation disorder. How does that happen? Well, we all carry probably a couple of dozen genes in our body, in our genetic information, that don't work. But because the other copy works, we don't have any symptoms. The only time that ends up being a problem is if by chance you happen to have a child with somebody who has a copy of the same gene that doesn't work. And in that setting, if mom passes on a copy of the gene that doesn't work, and dad passes on the copy of the gene that doesn't work, a baby gets no copies that work, excuse me, and you get the disorder. Let's use that math to answer the second half of the question. Will every child in a family have a fatty acid oxidation disorder? And the answer is no. Why not? Well, if both parents have one copy that works and one copy that doesn't work, they each pass on one or the other of those copies purely by chance. It's random. You either pass on one that works or you pass on the one that doesn't. And so it's only if dad has to pass on the copy that doesn't work, that's a 1/2 chance. and mom has to pass on the copy that doesn't work, that's another 1/2 chance. The likelihood of that occurring is calculated by statistics by multiplying the probability of those two things individually. So it's 1/2 times 1/2 equals 1/4. So in other words, 25% of the time, if each parent carries a fatty acid oxidation disorder gene, then 25% of the time a child will have it. Now that occurs for every pregnancy. So if you have a child with a fatty acid oxidation disorder with your first pregnancy, the chance that that second pregnancy will have a fatty acid oxidation disorder is still 25%. So it is true that if you are unlucky enough that you have 4 kids in a row with a fatty acid oxidation disorder, that's possible. However, on average, 1/4 of children in a family will have a fatty acid, the fatty acid oxidation disorder, and the other 3/4 will not. What are the different fatty acid oxidation disorders and how do they function? We've already started talking about some of these distinctions, and I'll go into a little bit more detail here. And I'll try not to overwhelm you because these are things that you can find lots of information online about the specific disorders. But let's go back to those categories that I talked about at the very beginning of this session. So the first thing that has to happen is carnitine has to be available for this for fatty acid oxidation disorder. There is a protein called the Carnitine Transporter that is necessary for carnitine to get from the bloodstream, usually from the diet, and then into the cells. There are some cells that can make carnitine, but then it also has to be transported around to the rest of the cells for it to be functional. So one type of fatty acid oxidation disorder is due to carnitine transporter or carnitine uptake deficiency. The next group of disorders are that carnitine cycle that bring the fat from inside the cell to inside the mitochondria. That's CPT1, CACT, and CPT2. And that set of reactions is only necessary for long chain fats. The medium chain and short chain fats, usually dietary in origin as opposed to the ones that you're getting from your body in storage, are somehow or other get into the mitochondria by themselves. So they don't need those transporter molecules. So CPT1, CACT, and CPT2 are part of the group of disorders that we call long chain fatty acid oxidation disorders because they only act on long chain fats. Now, once you're inside the mitochondria, the fats do this set of reactions that knock off 2 carbon units and then return a fat that's now 2 carbons shorter that starts all over again. That's a set of 4 reactions. Excuse me, but those 4 reactions are carried out by different enzymes depending on how long the carbon chain is for the fat. So once the long chain fats that we get from most of the fats in our diet and most from storage, those long chain fats get inside the mitochondria. They're using the 4 steps of long chain fatty acid oxidation that are inside the mitochondria. They are very long chain acyl-CoA dehydrogenase, VLCAD, and then the next 3 steps are part of a combined protein or a combined enzyme called the trifunctional protein, and that does the next 3 steps in the pathway until you get down to about, as I said, 10 carbon units, and then the next one enzymes kick in, and that's medium chain acyl-CoA dehydrogenase. And then down in that range, the next three steps are individual proteins. And those are the disorders of medium chain fatty acid oxidation. And then there's an enzyme that kicks in for that first step called short chain acyl-CoA dehydrogenase that starts the last cycle of that for the breakdown to occur. Defects in the carnitine transporter, that molecule that brings that protein that brings carnitine into the cell, look like long-chain fatty acid oxidation disorders. You tend to have a heart weakness, cardiomyopathy, low blood sugar, and muscle weakness. The disorders of long-chain fatty acid oxidation, including that three-step transport into mitochondria, as well as the cycle inside the mitochondria for long-chain fats, have a very similar clinical picture. And so we tend to think of them in the same context. That clinical picture, depending on your age, looks like low blood sugar, sometimes accompanied by liver problems, muscle weakness and muscle breakdown. That last thing, muscle breakdown, is called rhabdomyolysis, and then cardiomyopathy or muscle weakness. And some combination of those symptoms are what you see in the long-chain fatty acid oxidation disorders. For medium chain, the only one there that we have that we see a lot of is the MCAD, the medium chain acyl-CoA dehydrogenase deficiency, and that shows up pretty much as hypoglycemia, low blood sugar. Prior to knowing what that disorder was, we saw a lot of it in sudden infant death, because children who you didn't know had a problem, you let fast, or they got sick and they went to bed and they just never woke up. Now that we know what these disorders are, we don't see that happening anymore. So MCAD deficiency is largely a disorder of low blood sugar. And then short chain acyl-CoA dehydrogenase, or S-Cad deficiency, is really these days felt not to be a clinical condition. It's a biochemical phenomenon. Your blood accumulates some of these molecules that wouldn't otherwise be there, but the body seems to have enough energy to be able to function just fine, and those compounds that accumulate don't seem to cause any clinical problems. And so most of the older studies on S-Cad deficiency defined it as having all sorts of things, all sorts of clinical pictures. And the reason for that is that it was because it's completely coincidental. People looked at individuals, doctors looked at individuals with clinical problems, found short chain acyl-CoA dehydrogenase deficiency, and said, aha, they have to be linked. Well, they weren't. It was a completely coincidental finding. And we've got a lot of studies now, long-term studies, especially studies on babies identified in the newborn period, which we'll come to a little bit later, that have said that those individuals are really just fine. And if you have symptoms and you have S-Cad deficiency, you need to look for another problem for those symptoms. How and when are fatty acid oxidation disorders diagnosed? This is a two-part question on the how part, as well as actually a multi-part question on the when part. So let's deal with the how first. In the United States and many developed nations, fatty acid oxidation disorders are identified by newborn screening. At least most of them are. The severe versions of them are, and this is a good thing, because, as I mentioned before, if you don't identify these, the possibility is that you can get sick, very sick, very early in life, and not know what it is, and therefore not treat it properly. And because M-CAD deficiency and the fatty acid oxidation disorders can present in the first few days of life, in the United States, we've taken to identify them by newborn screening. This is that test that's done on all babies, unless you object to it on ethical or religious grounds. They prick the baby's heel, they drip the blood on a piece of filter paper, and they send it off to the state lab to test. So that test can identify these disorders. And usually that test comes back in time for your physicians to be able to treat your baby before he or she gets sick. Now, in very, very severe cases, the babies can get sick before that test comes back. So it doesn't always work the way we would like it to. Now, there are two caveats there. I just talked about one of them. That is, it can be your baby can get sick before the test comes back. But the other caveat is that there are milder forms of these diseases that might not trigger the newborn screen because there's enough of one of the enzyme that's not working properly to sort of be okay while the baby is small, and so there are no symptoms early on and no biochemical abnormalities that are identified in the blood on that screening test. And so mild versions of the fatty acid oxidation disorders can be will not show up with a newborn screen. Now the when part is I'm sorry. We have one more piece for that how part, and that is, what if you're in a country or someplace where newborn screening isn't done, and that then takes you back to where we were prior to newborn screening in those other countries, and that is it's a diagnosis that you have to think about to make the right diagnosis. And if you have somebody who has a problem with low blood sugar, muscle weakness, or this rhabdomyolysis that I mentioned, or cardiomyopathy, weak muscle, you have to do the right test or you won't find it. It doesn't show up on the tests that most doctors think about doing in a sick patient. Those tests are something called an acyl carnitine profile. That's a blood test, or a urine organic acid. That's a urine test, as the name implies, or a urine acyl glycine test. And when a patient is sick, those tests will show the breakdown products of fat that are building up behind the block. However, they can normalize when patients aren't sick or aren't fasting, because if you're not breaking down fat, those chemicals won't be there. So that's why I say you have to think about it. If you had a problem with your blood sugar yesterday and you ate and now your sugar's better, you go to your doctor is going to say, well, let me do some tests, and they're going to do the wrong tests, or even if they do the right tests, they might not see the abnormal signal that identifies the disease. So the blood and the urine tests that need to be done to identify those patients in older age, if newborn screening hasn't been done, you have to think about them. Just as an FYI, they're probably abnormal in the newborn period because being born is stressful. So you really are you've got your fatty acid oxidation turned on, and that's why they're abnormal. So let's turn to the when. When is essentially any time in life. If you're identified by newborn screening, you may be completely asymptomatic and trigger the newborn screen, and hopefully we get to you before your child before those symptoms develop, and you never get symptomatic. However, even in individuals who aren't have had newborn screening, you can now have symptoms at any time after that. So in severe disease, you might not have the symptoms that we hope you don't have, the symptoms that lead to the worst outcome, that is death, that you might have had without newborn screening. You still can get sick with these disorders, and so if you hadn't been identified by newborn screening, and you were 1, 2, 3, 10, 12, whatever, those abnormalities will be present, and you can have the diagnosis made at any time when the disease manifests itself. The next question is really a follow-up of that last one, and this: can an adult have an FAOD and never previously been diagnosed? And the answer is yes. There are mild forms of all of these disorders that quite frequently don't present until a patient or an individual is in late adolescence and early adulthood. Some of those, the metabolites, the chemicals that identify the disease, may be present in the newborn screen, but they may not. And so an adult with unexplained cardiomyopathy, or more frequently recurrent rhabdomyolysis, this muscle breakdown, needs to, the physicians that are seeing those patients need to think about fatty acid oxidation disorders and order the test to identify them. Now, in adults, I'll say that most often the diagnosis is made a little bit differently, because most of the physicians, other than genetic docs, don't know too much about these other tests. But what will happen is when you have rhabdomyolysis, one of the other proteins that's in muscle is called myoglobin, and that protein is red. And so what happens is you get a large amount of that in your blood, gets into urine. Your urine turns red or Coca-Cola colored. So if you go to your doctor and say, "I hurt like heck," because that's what rhabdomyolysis is, like running a marathon. If you're out of shape, it hurts. So you say, "I have muscle pain and my urine is dark colored," they should order a blood test called CPK, creatine kinase. That's another muscle protein that's elevated in blood. You can do a urine test with a very simple test that is usually done in an emergency room, looking for blood in the urine. So the test that measures that is called measures the iron that's part of that hemoglobin. It's also iron part of myoglobin. So the test that picks up hemoglobin and will pick up myoglobin. So you can dip the urine. That comes out being positive. You see CPK elevated in the blood, and that's rhabdomyolysis. That could be a fatty acid oxidation disorder. Now, there are other tests, there are other disorders besides fatty acid oxidation disorders that can do that, but that's that's one of the fatty acid oxidation disorders are one of the set of disorders that can do that. And the two most common that do that are the CPT2 deficiency. There's a common mutation that leads to late onset disease, usually not identified in babies at all. And it turns out that that particular mutation is very common in individuals of Ashkenazi Jewish heritage. And so the physicians who take care of a large number of individuals of that ethnic group should be aware of that diagnosis. And then VLCAD deficiency, the very long chain acyl-CoA dehydrogenase deficiency, there's another common mutation in that group in that enzyme that leads to late onset symptoms. But there's no ethnic group where that's predominant. So it's just a general phenomenon. how do the symptoms vary with the different fatty acid oxidation disorders? So we've covered this just a little bit, and that is that the long-chain fatty acid oxidation disorders tend to have a different set of symptoms than we'll just say MCAD deficiency, because that's really the only really relevant disorder in this group of disorders. So to review that, in long-chain fatty acid oxidation disorders, the things that we find are hypoglycemia, that with or without liver dysfunction, that tends to be early on, the first 2 to 4 years of life. By the time you get to be 2 to 4, usually more like 4, the incidence of low blood sugar starts decreasing, and the incidence of rhabdomyolysis starts increasing. Now, you can have rhabdo in the early years and months of life, but later on it tends not to have hypoglycemia with it, whereas early on you do tend to have the hypoglycemia with it. And so the rhabdo tends to occur after age 4 to 6. And in fact, more frequently, it gets worse with as you turn to adolescence. And so there you might have an episode or two from 6 to 12, and by 12-year-old, by the time you're 12 or later in adolescence or young adulthood, the episodes may happen more frequently. The cardiomyopathy in the long-chain fatty acid oxidation disorders can happen anytime. So you always have to be worried about that. It can be present and asymptomatic at birth. More often than not, it shows up a little bit later if it's going to show up usually in the first year of life. But if it isn't present in the first year of life, it can happen anytime. And that's why we always test for it in our routine follow-up of patients with fatty acid oxidation disorders. In medium-chain acyl-CoA dehydrogenase deficiency, the same thing is true with the hypoglycemia. That is, it tends to be more common in the first few years of life. Prior to being able to identify it by newborn screening, the patients showed up symptomatically most often between about 18 and 36 months of life, or 12 to 36 months of life. So in the first 3 years of life. However, it can happen very early on, within the first couple of days of life, and so we look for symptoms anytime in those first few years of life. By the time kids get to be 4 to 6 years of age, the hypoglycemia becomes much less frequent, and it's not completely gone. If you fast long enough, for example, you're in the hospital for some sort of surgical procedure, even an adult can eventually get hypoglycemic. But you've got more other ways that your body can generate energy, and so M-CAD deficiency tends to be less of an acute symptom in later life. A lot of my patients with M-CAD deficiencies will, however, say that they just don't have the energy that they think they should, or that sometimes their energy waxes and wanes, and they may have some muscle pains along with that. It's a little harder to quantitate that, and so it tends to be viewed as a minor symptom. If you have those symptoms, it's not minor, and especially if you're very active. You know, if you've been a runner, or you like to play, I don't know, basketball, hockey, whatever. It really can limit what you are able to do in that setting. What are the variations in treatments for the different fatty acid oxidation disorders? So we're going to stick here to our distinction of long-chain fatty acid oxidation disorders and M-CAD deficiency, because it is different. The common components are really to avoid the things that bring on the problem. So don't fast, and we'll come back to that in a second. If you're sick and you don't feel like eating, you at least have to keep up drinking sugar-containing solutions. The sports drinks, it turns out, don't have a lot of sugar, so you want to add some sugar to those. But juice or Kool-Aid, anything that's got a lot of sugar in it, you can use that. And then in some patients with fatty acid oxidation disorders, their carnitine levels can be low, and we'll sometimes supplement with that. So what's different in the two disorders? Well, in long-chain fatty acid oxidation disorders, there's a lot more residual symptoms. Remember I said with MCAD, oftentimes as you get older, you really don't need to do anything specific in treatment unless you get sick. In long-chain fatty acid oxidation disorders, we're always treating you. So number one, don't fast. What does that mean? Well, mostly that means you can't sleep overnight as long as you want. So those adolescents that like to sleep till noon, we can't let you do that. We have to limit your fasting with a long chain fatty acid oxidation disorder to. I like to keep it to 8 hours. It's probably okay to go 10, but I just don't like to risk it. For MCAD deficiency, early on, we restrict fasting. Later on, we probably don't really need to do that. Now, the length of time that you can fast directly depends on how old you are, and usually this refers to the first year or two of life. And in long-chain fatty acid oxidation disorders, I actually use the same number for MCAD deficiency. I say for the first 6 months of life, you should be waking up. You should not be fasting any longer than 4 hours at night. Some kids with long chain fat defects, that needs to be 3 hours. But basically, you're waking up once or twice a night to feed in those first 6 hours, those first 6 months of life. And that isn't too much different from what normal babies are doing up to 6 months of age. After 6 months of age, some folks will tell you can add an hour with every month of life, so that by the time you get to 12 months of age, you can fast with MCAD deficiency to up to 12 hours. As I said, I still keep it a little shorter than that. And with long chain fatty acid oxidation disorders, I basically go with 6 hours at 4 hours at 6 months of age. 8 months of age, I'm okay going to 6 hours, and by a year of age, I go up to 8 hours. That's my usual rule of thumb. And with MCAD deficiency, and with that, I don't increase it after that for long chain. For MCAD deficiency, I like to keep it at 8 hours through the first 2 to 3 years of life, because that's the highest risk time for having symptoms develop. And then after that, you want to go to 10, and then maybe even a little bit later, by the time you're age 6, for example, go to 12 hours of age. That I find that to be okay. When you're sick, you have to be able to keep calories going. If you're young, first couple of years of life, even if you can keep those calories going, I would typically say come to the hospital, because I want to get an IV into you to give you glucose to make sure that you don't get into trouble. If you have an episode of rhabdomyolysis, also depends on how old you are. In the early going, first 2 to 4 years of life, I'm much more likely to bring you into the hospital for that than I am beyond that, where at home we can just treat you with lots of oral fluids instead of IV fluids. But early on, I want to watch you and make sure that you don't get into trouble. And if you have any symptoms of heart problems, and those are complicated and probably more than we can talk about here, but I could say that at the very least, it's rapid heart rate, easy fatigability, or you look like you're having trouble catching your breath. Those are all things that say you just come in and let us treat you. In the hospital, we'll give you high levels of glucose. We might give you some other salts in that IV fluid to keep you in balance, and then we'll drop it down slowly if you have rhabdomyolysis as your CPK drops. With MCAD deficiency, basically, as soon as you're able to take oral fluids again, it's going to be safe to go home if you had to come into the hospital. So a lot of this depends on communication between you and your physician, your metabolic doctor. I ask parents to call when their children are sick, and let me know how they're doing. Usually in the early going, the first question is, should I come to the hospital? My first question back is, what do you think? Because usually you're the one that knows what to do. If you're at all uncomfortable, you come to the hospital. If you say, well, my child's eating well, I think I can keep up on fluids, looks like their urine is clear, we give you those dipsticks to check that myoglobin in the urine at home, I think I can handle it. Fine, I think you can handle it as well. So that's really the working relationship here. Carnitine is one of those drugs that sometimes we use it and sometimes we don't. You might hear some concern raised about the possibility of some toxic side effects. I have to say, I actually don't believe it. It's never really been shown. There are no good clinical studies to show it. And I do know that if your carnitine level drops low enough, and low enough I define, we measure two carnitine parameters, free and total. And if your free carnitine is lower than 10 or 12, I give you a little bit of carnitine. If you have carnitine transporter defect, you get a ton of carnitine. There's no concern there because what we want to do is flood you with enough carnitine that it just leaches into your system without having to need that, need that specific transporter. So I would say that probably almost all of my MCAD patients don't need carnitine. In fact, after a while, I just don't check it anymore. And unless you're symptomatic, and by symptomatic, that means muscle weakness or a lot of muscle fatigue, I just don't check it. In my long chain fat oxidation patients, I always check the carnitine level, and if we get down into that single digit level, I'll give you a little bit just to try to boost it up to the low normal range. Let's see if I missed anything. Diet. A lot of misinformation or misconceptions about diet. In long chain fatty acid oxidation disorders, there's actually no data that suggests that a low fat diet makes a difference. Because when you eat, the fat that you take in doesn't get metabolized for fuel. It gets stored. And whether you're on a low-fat diet or a high-fat diet, you tend to store the same amount of that fat. If you get a high-fat diet, you store more and you might get overweight, but it's not dangerous per se for your fatty acid oxidation disorder. The problem is that where you get into difficulty is the next thing that we're going to talk about, which is medium chain supplementation. If we're giving you medium chain fats, we want the total amount of fat that you take to still be in balance with the rest of your diet. And so if we're giving you a lot of fat as medium chain, you're going to have to drop the long chain or natural fat in your diet to allow you to take that extra medium chain fat. So for the most part, what I end up telling families is if you can keep your natural fat down to about 20%, that's going to be sufficient to allow me to give you enough of the medium chain fat to work. And in our infant formulas, well, we just go ahead and keep the long chain fat down to 10% because you don't need any more than that. And we'll just give you the rest as a fat that you can use as a medium chain fat. For MCAD deficiency, they just don't do any fat restriction at all. You can't use medium chain fat, so we don't give you that. That's not an option. So I just tell families, follow a heart healthy diet. If you're getting 30 to 35% of your calories from fat, that's a heart healthy diet, and it's a good way. It's just a good healthy diet. So go ahead and do that. The final component that we'll talk about here is the medium chain triglyceride oil. And until recently, that was really the only other thing we had to offer as an alternative fuel source. If you can't use long chain fats, and medium chain fats can get into mitochondria without and be metabolized without that long chain pathway, then let's give you a lot of medium chain triglyceride oil. And that was okay to a certain extent, but it didn't really work as well as we would like. And I'll come back to that in a second. In medium chain deficiency, MCAD deficiency, you don't want to take MCT oil because it can be toxic. It can make you sick, and so stay away from it. The tiny little bit that you might get from, say, coconut in a cookie, it's not. That's where medium chain triglyceride oil comes from. It's in coconut oil. So that little bit's not going to hurt you. But you don't want to cook with coconut oil, for example, or you don't want to, I don't know, eat sticky rice from a Thai restaurant, which has got a ton of coconut oil in it. So those are the few restrictions that I would think about in MCAD deficiency. Now let's go back to MCT oil and long chain fatty acid oxidation disorders, and talk about why they don't necessarily work as well as we would like them to. Since fatty acid oxidation disorders are knocking off these 2 carbon units at a time, I haven't told you how that's turned into energy. Well, that's turned into energy by going into a second energy cycle called the Tca cycle, or the tricarboxylic acid cycle. And it uses those 2 carbon units to make the chemical that goes to the third pathway called the respiratory chain, which is what makes the energy that the cell uses. The energy is called ATP. There are 2 steps in fatty acid oxidation that directly make these same chemicals. They're called reducing equivalents. About a third of the energy from long chain fat comes from that side of the equation. The other 2/3 come from the Tca cycle. So if you have a long chain fat defect and you're using MCT oil, you've already cut the total amount of energy that you can generate by half, because you're only using C8. That's what most of MCT oil is, instead of C16, the most common fat stored in the body. And so you're already behind the 8 ball there. Now, as those 2 carbon units go into the Tca cycle, what happens is the Tca, and we're really pushing the Tca cycle to work now, because you're generating more of your energy from there than you are from fat metabolism. So your Tca cycle runs and it runs and it runs and it runs. The problem is that the Tca cycle needs not just those 2 carbon units that are coming from the medium chain triglyceride oil, the C8, but it also needs odd chain carbons to function properly. So it runs and it runs and it runs and it runs until it runs out of 3 carbon units. Where do you get 3 carbon units from? Well, you can get it from some amino acids. You can get it from some natural fats, but for the most part, you don't have enough in your body to make that work. And that's the theory behind the drug that's recently been approved for long-chain fatty acid oxidation disorders, triheptano, and that's the generic name, or Jolvi, that's the brand name. And that is an odd chain carbon. It's C7. It's still medium chain, so it can get in and bypass those long chain enzymes. But because it's odd chain, the first time you go through fatty acid oxidation, you get a 2 carbon unit. Now you have a 5 carbon unit left. The second time you go through fatty acid oxidation, you get a second 2 carbon unit, but now you got a 3 carbon unit. That can't be metabolized by fatty acid oxidation disorder. That goes directly into the a different pathway and is utilized to make the 3 carbon units for the Tca cycle. So it's a more balanced fuel for patients with long-chain fatty acid oxidation disorders, and I just think everybody should be on it. I don't. It's only been approved for about a year now, and so there's going to be a slow transition from using standard MCT oil to triheptanoin. But in the clinical trials for triheptanoin, patients had a dramatic reduction in their symptoms. No hypoglycemia, at least a 75% reduction in the risk for cardiomyopathy, and somewhere between a third and a half reduction of the incidence of rhabdomyolysis. So it's a much better fuel than MCT oil, and I think everybody on a long-chain fatty acid oxidation disorder who's using an MCT oil supplementation should be using triheptanoin instead. There's some other supplements that are used under special circumstances. I did mention before that individuals with the trifunctional protein deficiency have 2 unique symptoms that aren't common to the other fatty acid oxidation disorders. They can develop deterioration of their retina, called a retinopathy, and they can develop dysfunction of the nerves coming from the spinal column to the muscles, called a peripheral neuropathy. And if you have a deficiency of just one of those trifunctional protein enzymes called LCHAD, or long-chain 3-hydroxyacyl-CoA dehydrogenase, you have mild neuropathy, but are at risk to have a progressive retinopathy that can in fact lead to pretty significant visual impairment and even blindness. And if you have the full trifunctional protein deficiency, you tend not to have the eye problems, or maybe just a mild version of it, but you have a very bad peripheral neuropathy. There is a supplement called DHA, which is an over-the-counter vitamin essentially, that can slow the progression of those 2 symptoms down, though it doesn't completely stop them or eliminate them. So if you've got trifunctional protein deficiency, we're also supplementing you with DHA to try to help correct those symptoms. I've mentioned that there are still some residual symptoms regardless of the therapy here. And what that points to is that we need better therapies. And one of the other things that I'll be talking about later in this symposium are some of the new therapies that are coming down the road that are under development now, that hopefully in the not too distant future we'll be able to use some combination of these therapies and eliminate the symptoms related to these disorders, and that includes gene therapy going forward. So I think that's enough about the treatments for these disorders for now. It gets a little overwhelming if we go into anything more. The next question is, what does current data show about the prognosis of different fatty acid oxidation disorders? And this turns out to be, unfortunately, a really tough question to answer. If you look at the old literature, and by old literature, I mean the literature that comes out from countries before they took on newborn screening. And in that setting, for the long-chain fatty acid oxidation disorders, it says you got a 70% chance of dying before you get to adulthood. Now, fortunately, that's no longer the case. And in the context of newborn screening, the risk of death is quite significantly reduced. Now, I can't tell you exactly what it is, but it's certainly a very small number, a handful of percent. And that's because some of the most severe forms of the long-chain defects present early enough that it's hard to treat. We can't get you out of the newborn period. Or if we do, you've got bad enough heart disease that's really what's life limiting. So there's a small percentage of patients who die in infancy or early childhood from their heart disease. If that doesn't happen, then the likelihood of you dying is actually very, very small. Sure, you can have a catastrophic event later in life caused by a very severe illness, but for the most part, we can control your symptoms well enough to say that at least we know you can make it to adulthood. Now, why do I stop there? Well, that's because we've only been screening for these disorders for on the order of 20 years. And so we don't have a lot of what happens to those babies who are now 20 or 25, and do they hit 50? Do they hit 70? And we're just going to have to learn along with you what happens there. I will say that for the individuals who were identified symptomatically in their teens, early adulthood, so milder disease, we know that those individuals can live normal lifespans. With the additional therapies coming down the road, hopefully the answer to this question 5 years from now is you'll have a normal lifespan and a normal lifestyle. We'll certainly be watching that with you, and hopefully I'll be able to convince you to participate in the clinical trials that'll be necessary to get those therapies approved. You'll see those, as I said in my my talk later in this symposium. For MCAD deficiency, the answer is very different. If you are identified in the newborn period, we can treat you and we can unequivocally give you a normal lifestyle and lifespan. You have to watch out for hypoglycemia as parents in your child in those early years, but after that, there is no reason that you should, there certainly is no a reason why you should have a shortened lifespan. So it's a little bit of a complicated answer for the long-chain fatty acid oxidation disorders, and all I can say is that we're working very hard to be sure that the quality of life continues to improve over time as our therapies get better. Well, actually, this is sort of a continuation of what I've already been talking about, and that is, can a patient with an FAOD lead a normal life and participate in regular activities? I'm going to take the MCAD part first because it is simpler, and that is, outside of those early years where I'm telling you to be careful about how long you sleep, or you're telling your parents about how long you let your kids sleep, the answer is yes. We have patients with MCAD deficiency who have participated in high-level sports in high school and college. Sometimes they say they run out of steam a little sooner than they'd like, and they just stop and take nutrition and then get going again. But that the long-term implications of that are less or become less as you get older. It is much more complicated with a long-chain fatty acid oxidation disorders for much of the same reasons that I just talked about in answer to the previous question, and that is that although our current therapies make improve things, it doesn't eliminate symptoms, and so we're always going to be following you. I would say that the majority of our 1 to 4 or 5 year olds end up in the hospital once or twice a year. That once you get to about 6 to 12, that that decreases, but it also depends on how frequently you have your episodes of rhabdomyolysis and how well you can handle those at home. And then in our adults, we're usually able to take care of things at home. However, if the levels go too high, your muscle breakdown is too significant, then we still do need to bring you into the hospital to keep to make sure you don't end up with some of the kidney damage that can happen as a result of that myoglobin that builds up in your kidneys related to the muscle breakdown. We do try to have our patients participate in as much in regular activities as possible, to make that happen, we really rely on parents and kids to tell us, or older patients to tell us what's working and what's not. And if you tell us that you're just fine participating in basketball, then you can go ahead and participate in basketball. We'll help you with that. We give you guidelines about taking a good nutrition before a sporting event, stopping halfway through the event to take some additional calories, usually some fruit juice or something like that. And it turns out that if you take a dose of your triheptanone or MCT oil just before you do that activity, 20 to 30 minutes beforehand, you can do even better. However, if you say to us, every time I try to swim, I get muscle breakdown, then I'm going to have to tell you, then don't swim. Or I can play basketball for 30 minutes, but not for an hour. Okay, then play basketball for 30 minutes, but not for an hour. So that's the kind of, it becomes real practical then, and we'll be working with you on trying to identify what your limits are or what your child's limits are. And that's really because every mutation that causes these disorders has a little bit of a different effect. And so we're trying to really learn what that effect is on you or your child, and work with that going forward. And I guess that's the last question. So what I invite you to do is to please participate in the upcoming family forum that MitoAction is sponsoring, and our Inform organization is helping to organize and provide content for. I invite you to look at the Inform Families webpage. We're working hard to try to improve the content on that page as we move forward, and really help you manage your fatty acid oxidation disorder or your child's fatty acid oxidation disorder, so you can optimize, if not normalize, yours or your child's lifestyle. So thanks. Hope you enjoy the conference, and I hope you've learned something from this. Hopefully, I'll have the opportunity to talk to you at a future family event.